Well, good morning, everybody. Welcome to this value-based procurement in healthcare webinar. Let's give you a couple more minutes before we start because people is still joining the session. So we will be starting in a couple of minutes. Okay, it is a couple of minutes already past the starting time, but I can see people that is still joining. Let's see just one more minute before we start, okay? We'll get to it right away. Okay. Well, I think it's time we start since we have a tight agenda, and anyhow, even though people is still joining, but let's begin with this very interesting webinar on value-based procurement in healthcare, turning theory into action, co-organized by the Procure for Health community and the value-based community of practice. My name is Carlos Larrañeta. I'm the Procure for Health Community Coordinator, and I work for the Andalusian Public Health System. Very briefly, for those who don't know who we are, Andalusian Public Health System is a very large health system. We provide services to almost a population of 9 million persons. We have 52 hospitals and over 1,000 primary health centers. And we are around 100,000 employees. So, I mean, we're the biggest enterprise in Spain, only behind the army. And as I said, I do coordinate the Procure for Health community. First, before we start, some housekeeping rules. This webinar is being recorded. The recording and the presentations will be made available on the project website 2-3 days tops after today's session. We have a very large audience today, so an open mic discussion might not be feasible. So please, any question that you have while the presentations are being made, please post them in the Q&A session. We will be addressing as many as we can during the time we have for discussions, but there will be also a Q&A document published with in which we will try to address all your questions together with the recording and the presentations, and take into account that the list of participants will not be shared. Okay, for today's agenda, this is today's agenda. I'm going to start by introducing who is Procure for Health, what are our objectives, and why value-based healthcare is so important for us. One of the things that we will be highlighting today is how important is the communication and cooperation among the demand of innovative solutions and the suppliers of innovative solutions. This is why we, Procure for Health community, are working closely with the value-based community of practice to foster this communication. So right after me, Hans Bax will be introducing value-based community of practice. Then Helen Yu and Hamish Lanes from the University of Swansea and the Value-Based Healthcare Academy will contextualize what is our approach, Procure for Health approach regarding value-based procurement. And then we will get into some practical examples of already implemented or under deployment of outcome-based contracts. And finally, we will have some time for discussions and conclusions. Since we have a tight agenda, let me briefly introduce who is Procure for Health. This is how we started. We are a number of procurers of the health and care from the health sector that want to foster the adoption of innovations to improve the services we provide. As I said, we started with output procurers from 13 different countries almost 2 years ago, and this is who we are right now. So we can proudly say that if you want to know what's going on regarding the adoption of innovation among the health and care services providers in Europe, this is the place to be. But what is our scope? As I said, we want to foster the uptake of innovation that improve the life of our end users, clinicians, and patients. For us, adopting innovation is procuring innovations. And what we're working is to build our capacities in order to be able to do so, to create networks that allow us to gain muscle, strength, that once again that allow us to share risk and benefits, and last but not least, to improve the efficiency of the procurement of innovation instruments. One of the main activities, instruments we have in order to achieve this are our working groups. This is the list of working groups we have up and running in Procure for Health. You can see that there is 4 that we can say vertical working groups addressing clinical topics, digital healthcare and ICT, integrated care, sustainability in procurement of innovation, and personalized medicine. What these working groups are doing is assessing, defining, and prioritizing common unmet needs of innovation. This is a work that has already been done, and we are already conducting open market consultation for those that we have prioritized. We had a couple of weeks ago the first one on on-site water treatment of hospital wastewater. The 8th of May, we're having the second one on reusable personal protection systems for clinicians. In June, we have the third one, which is about remote home monitoring of chronic patients with multiple conditions. And right after summer, in September, we will have the last one of those that are already in the agenda, which is on the preservation of fresh samples. So these are our 4 vertical working groups. But as I said, we also want to improve the efficiency of the instruments. How do we use it? For that, we have 2, let's say, transversal working groups. One is impactful innovation, let's say, devoted or dedicated to overcome the infamous valley of death of going from piloting to adoption. And last but not least, obviously, is our value-based healthcare working group. Last, and wanted to outline the importance of value-based for us, for the adoption of innovations. As I said before, the main final objective is that we are able to improve the services by taking advantage of the innovations that are being developed around us. So adoption of innovation is procurement of innovation, and to be able to do that, we have to be innovative in the way we procure. This innovation adoption process is a process that must be launched by the demand, by us, by doing a detailed definition and prioritization of what are our needs. Right after that, we have to engage with the market. We have to learn how far is the innovation ecosystem of providing a solution, money-wise, time-wise, for instance. And then we have to launch and turn the procurement. There are a number of important reasons why value-based procurement facilitates the early introduction of innovations, and a number of good practices to do so. Our experts will tackle that right after me. But for me, there is a very clear reason. Being realistic when developing and adopting innovations, we are hardly going to get a binary solution. One fully works, full impact, or zero complete failure. In reality, we will reach different levels of impact, of added value. We, as the demand, have the obligation to get the best value for our money. But we also have to be able to launch appealing tender processes and contracts for the supply to engage. That means sharing risk and rewards. And for me, that's value-based procurement. So that's it from my side as an introduction. Now I leave the floor to Hans Bax from the Value-Based Community of Practice. Hans, the floor is yours.
Great, Carlos, and thank you for having me today. So good morning to all of you. My name is Hans Bax, and as introduced by Carlos, I'm leading the European Value-Based Procurement Community of Practice. Now, traditionally, the key role of procurement in healthcare has always been to safeguard availability of goods and services needed for our healthcare providers to provide healthcare and cure to our patients. And then seen as a major cost driver in most healthcare provider organizations to then try to negotiate better prices and higher discounts for all these medical technologies. But fortunately, also much progress has been made in recent years, where purchases in several European countries and beyond have increasingly included the unmet needs of medical staff, clinicians, nurses in their public tenders and in the RFPs for new contracts. Next slide, please, Carlos. Okay, yeah, great, thanks. However, today, healthcare systems across Europe, they face some major common challenges. On one hand, we see this increased demand for healthcare services due to aging and chronic diseases. We have to face rising inflation, increased cost of energy, lack of qualified nurses, staff shortages, inefficiencies also in healthcare pathway, and most important, an urgent need to actually improve the outcome of our healthcare services and to manage the total cost of care delivery and not just to focus on the price of medical technologies. And then more specifically, procurers, they have to deal with supply chain disruptions and how to incorporate sustainability demands in their procurement activities. Next slide, please. So when looking closer into actually what now drives healthcare and patient outcome, it is also the medical technology having a significant impact on patient outcome, besides the patient and healthcare provider characteristics. So therefore, medtech not only has an impact on direct patient outcome, but it may also support solving and helping healthcare provider organizations to face the challenges by making healthcare delivery more efficient and more effective. However, many innovative medical technologies are not yet implemented because either their impact on outcome is not well understood or not sufficiently proven. Reimbursement and funding systems may not support fast provider and patient access to innovative medical technologies, or procurement practices remain executed in a kind of traditional volume-based manner. Next slide, please. Therefore, in order to support the healthcare challenges I introduced, we truly need a new procurement paradigm. What we call a value-based procurement approach that not only considers the price of the device, but also considers the impact of medical technologies on predefined patient outcome and the impact on the overall healthcare cost in order to manage these costs and to improve these patient outcomes. Now, this value-based procurement framework, which has been developed a couple of years ago by the community of practice, may be a helpful tool in the preparation of public tenders by actually identifying on which type of patient outcome the medical technology to be tendered, to be negotiated, should have an impact on. Next slide. And applying this methodology, looking at the tier 1, the tier 2, and the tier 3 patient outcome already identified by Michael Porter and Elizabeth Thijsberg in 2006, public tender criteria may relate to, for example, faster diagnosis, the reduction in the length of stay, the reduction in surgical site infections, the reduction of resurgery rates, and the reduction of longer-term side effects of initial treatment. So really trying to identify what is the issue we want to tackle, where do we want to improve, and to use those criteria in the public procurement tender process. And by doing so, supporting healthcare providers facing the challenges I introduced at the beginning of my presentation, and so making healthcare delivery more effective and more efficient overall. Next slide. Now, we, and then I mean some leading procurement organizations from across Europe, Medtech Europe and the Boston Consulting Group, we started our value-based procurement journey back in 2015, right after the new EU Public Procurement Directive in 2014, where the most economic advantageous tender principle was advocated for. That was actually the trigger for us to start working and developing this concept of value-based procurement. And throughout the years until today, we have developed some white papers, some reflection documents, and then in 2016, we initiated this value-based procurement committee of practice. And ever since, we organize webinars such as the one we have today, and we had the annual VBP conference in Brussels, and we now actually are preparing for the 6th edition for December later this year. Next slide. So today, the Value-Based Procurement Community of Practice is a network of procurers, public procurers in healthcare from across Europe, and representatives from the medtech industry supporting the introduction, application, and dissemination of this value-based procurement approach. And as said, we organize webinars, we have the annual VBP conference, and we provide various presentations and lectures at conferences, universities, and so on. But most important, we share our knowledge and we try to share best practices from within the community and beyond. And therefore, I think it's really interesting to have this joint session today with the Procure for Health network. And today and later on, two of our members representing Denmark and France, they will introduce two of the value-based procurement case examples being executed. And Carlos, I think I'll leave it by these words in order to keep track of time. And then actually I pass on to Helen and Hamish of Swansea University. Thank you very much.
Thank you very much, Hans. I will stop sharing now, and Hamish, the floor is yours.
Thank you very much indeed. Thank you. Just okay, so thank you very much indeed, and good morning to all of you. My colleague Helen is going to start this brief session about the theoretical approach to value-based procurement.
Good morning, everyone. Thank you for joining the webinar on value-based procurement. I'm Helen, Associate Professor and Associate Director of the Value-Based Health and Care Academy at Swansea University School of Management. As part of the Procure for Health Value-Based Procurement Working Group, the Academy has been working with the team to develop a framework for putting value-based procurement of health and care innovations into action. And as the lawyer in the group, I have mainly been looking at ways we can use the legal framework to facilitate value-based procurement and innovative procurement. We all know procurement of medicines and medical technologies are major areas of expense for health systems. And the traditional approach, the traditional procurement approach, has always been quite highly regulated, transactional, and focused primarily on price reduction and cost containment. What we're trying to do is adopt and change and pivot to the concept of value-based procurement, which attempts to move this very traditional prioritization in procurement from cost and volume to value. By focusing on the outcomes that matter most to people and allocating resources to interventions that create the greatest value through improved outcomes, there's a greater likelihood we can identify and stop doing things that are of little or no value. Changing this from the traditional approach of procurement from cost and volume to value also opens the door and helps turn our attention to innovations that improve efficiency of care delivery. And it also allows for consideration of wider benefits like environmental sustainability, innovations that contribute to reducing the demands disease places on family and the system to treat and provide care over the course of a person's lifetime. Conceptually, value-based procurement, it's not too hard to understand or get behind, but pragmatically, without an appropriate framework that takes into consideration and balances the social, political, financial, legal, and administrative pressures associated with procurement, there will always be implementation challenges and frustrations. Next slide, please. Hamish, next slide, please. Thank you. The framework that the working group is developing to support the wider implementation of value-based procurement in Europe is made up of two parts. The value-based procurement approach that requires active, responsive, and inclusive engagement with healthcare professionals, industry suppliers, and ideally patient group representatives as well. Step 2 looks to define the outcomes that should drive tender criteria and outcomes-based agreement. The procurement approach in step 1 can be broken down into 3 phases. In brief, we're talking about a phase 1 pre-procurement engagement process that asks the market to develop an innovative proposal through an open engagement process with all stakeholders. We're not talking only just about industry suppliers, but we're also talking about clinicians and patient groups to ensure that the final open tender includes concrete proposals, that reflects the interests and concerns of all stakeholders. In phase 2, the procurement organization evaluates the proposals. So the value proposition of the whole proposal's life cycle should be considered. So we're talking about actual measurability of value being pragmatically and realistically identified. And this can be elucidated through the inclusive engagement process that we've talked about in phase 1 to basically collectively manage the expectations and recognize the practical constraints of what these outcomes may be. The third phase is to design tenders according to selected proposals where there's an opportunity to include reward criterion that reflects value, for example, through an outcomes-based agreement. If a concrete value has been measured, then the procurement organization needs to help find ways to recognize the value and pay for the savings raised. Hamish will speak more about the outcomes-based agreements, but I just quickly want to mention that the Academy will be hosting an in-person event in June in Swansea to explore that phase 1, that value-based procurement approach in greater detail, and particularly in the context of using innovation partnership procedure under Article 31 of the Public Procurement Directive. Over to you, Hamish.
Thanks very much, Helen. Our focus in the Academy and indeed in this webinar is about the practical implementation of outcome-based agreements and value-based procurement. There is quite a lot published already about this, and just in the New England Journal of Medicine 8 years ago now, a really helpful summary of what are some of the key success factors for it. The idea that you should be setting an outcome-based agreement in the context of a partnership for value that is about solving problems rather than necessarily selling product. We tend to focus on procuring product, whereas health systems face huge challenges, and it should really be about how we solve problems. There needs to be shared accountability between the partners for delivering the outcomes. There should be measurement of the outcomes at every stage of the pathway that the procurement is about. And the idea, as others have already said, is to deliver value for patients and the health system and shared value for the supplier through innovation. And this requires the creation of new business models and payment systems that align financial incentives to the delivery of value. And again, this is the subject of today's webinar. It is also, of course, necessary, if you're going to understand the value of an intervention, you need to understand the costs. And so you have to capture costs across the whole pathway of care. And health systems are getting much better at this now than they used to be. And critically, in order, if we are going to achieve high value and better outcomes within the resources that health systems have, we have to stop doing things that don't deliver any value. And just incidentally, all those low value activities are also just wasting carbon. They're creating a carbon footprint with no benefit. So another reason why we should stop it. Now, all of this requires a degree of trust between supplier and procurer and health system, and that hasn't always been the case. And so we need to find ways of building trust if these agreements are going to work. And it may be, and the evidence suggests, that perhaps starting small, building trust, building relationships, and then being more ambitious may be a prudent approach. In terms of the practical implementation of an outcome-based agreement, we've done quite a lot of research on this, and some of what I'm going to say, my next two slides, are based on work we did that was funded by Pfizer, which was to create an outcome-based agreement in shadow form, but to work through all the steps required to successfully create an effective outcome-based agreement. So there are 12 steps. So the first is you have to consider whether the product or the service that you're thinking of procuring is actually suitable for an outcome-based agreement. And there are a number of considerations about that. Some are commercial, but some are practical. It's no good if the outcome that you're talking about isn't going to be manifest maybe for 10 years. Really hard to create an agreement about that. And you have to have measurable outcomes that you can use. You then need to define the eligible patient population, or the cohort of patients who will be included in the agreement. It may not be everybody who's receiving that product or medicine or service. It may be a defined cohort. And this is really important, both in terms of monitoring the performance of the agreement, but also creating the baseline so that you can say, well, this is how it was before we introduced that intervention. You need to be really clear about that. And that may take a little bit of discussion. You need to agree then the outcomes that you're going to use, and typically these would be clinical outcomes, but in the spirit of value-based healthcare, we would expect over time to see patient-reported outcomes being included, and then also potentially measures of resource utilization, technical value, if you like. And this is an opportunity to involve clinicians and even potentially patient groups in the construction of the agreement. Again, something that is not necessarily usual practice. You then need to define how you're going to measure each outcome. And are there sub-cohorts within your patient group who might have different measures used? And you need to agree the outcome benchmark. In other words, what are you benchmarking against? And that comes back to defining the original population that will be included. And then if you have a number of outcomes, and you may well end up with a number of outcomes that you want to measure for this agreement, well, then how are you going to deal with those? Are you going to aggregate them? Are you going to somehow construct a single outcome measure from those? Are you going to include all of them? If you've got, are you going to have a basket of measures? Are you going to weight them? And so on. So these are all practical things that you need to work through. Then you need to agree the terms of the contract, and over what period of time will you measure the outcomes? For example, are you going to say, well, we'll measure the outcomes at a year after the patient has received the product or service or medicine? You need to be really clear about that, because outcomes will vary over time, and that, of course, will affect how the outcome framework works. And then a really fundamental question is this a reward contract? In other words, could the supplier be paid more than 100% of the cost if the outcomes are even better than expected? Or is it a rebate contract? In other words, the most that the supplier could receive is 100%, but if they don't deliver the outcomes, or the outcomes are not delivered, then there is some form of rebate constructed. And again, in the spirit of value-based healthcare, you would want to see something that is rewarding continuous improvement and better outcomes. But it's perhaps easier to operate a rebate contract. Then what proportion of the price of the product or service is going to be included in the outcome element? Is it all of it? Or is it just a proportion? maybe in the spirit of building trust, you might want to start with quite a small proportion, maybe 10 or 20% of the value is variable, and the rest is fixed to create confidence, and then over time you can become more ambitious about what percentage is included. And then there's a technical element of how you're going to take those outcomes performance and convert them into the payment mechanism. And there's quite a lot of technical thought about that. For example, are these binary things? Are they achieved or not achieved? Or are there grades of achievement? Maybe we reduced admissions to hospital by a certain amount, but not by as much as we hoped. Well, is that a partial achievement? And then you need to make some provision for contract parameter updates and review. There will be inevitably, these are complicated things, and there will inevitably be some unpredicted outcomes that nobody had considered, and yet may adversely affect the performance of the agreement. And so you do need the opportunity for some form of mature and grown-up discussion that goes, well, none of us were expecting that outcome. How are we going to deal with that? And do we need to adjust the terms of the contract to reflect it? And then the final question, which is considered in a lot of outcome-based agreements, is the value of a trusted third party who would hold the data, the outcomes data, and also the contract data, and might even drive the contract operation, where both supplier and procurer can have equal views on the data, because it's important that both parties can see the data, but that they're being managed by a trusted third party. And that has been a model that has been adopted in a number of OBAs. And that depends a bit on the maturity of your system and your data and your contract management processes. So there are a lot of steps to work through, but we think that if you do work through those, then you can construct an OBA that will be effective and work. And there are, of course, suppliers who can help with the trusted third party and platform element. So I'm going to stop there. Just a reminder, and I see people are already posting some questions in the Q&A. Thank you. Please do continue to do so, and we'll pick them up at the end, as many as we can. And I'm now going to introduce colleagues from Italy, from ARIA, who are going to give us our first worked example of value-based procurement. So over to Marco and Elisa from ARIA. Great, we have your slides. Thank you.
Okay.
We can see your slides, but we can't see you, Marco. Do you want to put the camera on?
Imagine it's near me. Non si vede? Okay.
Yeah. Okay.
Thank you, Hamish. Hello to everybody. First of all, thank you for the opportunity to talk about this important topic, value-based procurement, and the solution we have to define in order to bring innovation to the healthcare system. First of all, let me introduce myself. I'm Marco Pantera, the Purchasing Director of ARIA. ARIA is the procurement authority of Lombardy region. The region is located in northern Italy, and it represents about 17% of the entire nation. In terms of numbers, ARIA publishes between 80 and 100 procurement tenders per year, with an economic value between 5 and 10 billion euros. The majority of these tenders are mainly directed to the healthcare system. With me, Elisa Dautiglia.
Hi, everybody. I am Elisa Dautiglia, biomedical engineer, and I am medical device tenders manager in ARIA.
So let's go to present how ARIA is concretely approaching the value-based procurement in terms of methodology, and we'll show the experience we have gained through some examples. So I start by illustrating the framework that we have defined, and then Elisa will share the real experience we have acquired. First of all, I want to underline that the framework has been designed to enable value-based procurement by selecting the contractor through a bidding process. Value-based is strictly connected to the innovation. So we have to take into account the innovation, the characteristic of the innovation. So the aspect that characterize the procurement of innovation, a procurement of goods and services, let's say solutions, are first, specifying the technical features of innovative products does not guarantee market competition and usually makes this product or solution unique and non-fungible. Second, innovative solutions come with higher prices compared to traditional solutions, which this fact obstruct competitive procedures. And third, taking higher costs carry risk for the healthcare system, as it may pay for solutions that do not deliver the promised benefit. To acquire this innovative solution, a hospital, for example, assume the risk of unachieved results in terms of quality and performance. So, keeping in mind this three characteristics, the challenge that ARIA has undertaken is the identification of procurement solutions that allow for introduction of innovation into the system, considering two perspectives. The demand perspective, the procurement solution has to promote the introduction of innovative solutions at the same time minimizing the associated economical risks. The market perspective is the second perspective. The procurement solution has to provide to the market a tool that allows innovation, the introduction from the industry suppliers, the innovation to the healthcare system. So, according to these points, we focused on a creation of, let's say, competition field in which the tender addresses standard quality features. In other words, the competition takes place based on the standard qualitative requirement. Secondly, the competition involves an additional payment for solutions that demonstrate providing values results to a healthcare system. I want to point out that the value can be identified by considering the benefits that the solutions brings to the patient care pathway in the entire pathway involving the patient. For example, a use of a technology results in a reduction of hospitalization beds, or in a reduction of use of production factors, or improve clinical outcomes. So, innovative solution can receive payment based on the value they will be able to provide, but we recognize this extra fee only after we observe the value that the solution gives to the healthcare system. So, a necessary condition to that condition is that we need to have the right method in order to measure the value, in order to pay innovation. And the condition is that the data through which the value is measured must be available without requiring additional activities to the healthcare professional to produce them. The professional has to take care of the patient, and the data has to be produced by the information system, hospital information system, for example. So, I briefly summarize the three phases that make up our methodology. The first phase consists in an open call in order to collect market proposal. proposal by the industry supplier. Proposals must be expressed by specifying the value, the metric in order to discover the value, and the necessary data to measure the value and to apply the metrics. So the second phase consists in the evaluation made by the purchasing authority, in the evaluation of all submitted proposals according to their concreteness in terms of saving the value for the healthcare system and in terms of easy of its measurement. The last and third phase consist in two sub-phases, the design and tender execution. In the design sub-phases, the proposal is inserted into a tender. So we define this phase. We define the tender, addressing all the aspects in order to recognize and to measure the value and to pay the value we will be able to recognize. In the second sub-phases is the execution phase, where we act what we wrote in the tender in order to measure, to discover, to measure the value and to pay the innovation. Now I'll hand over to Elisa, who will describe the experience we've gained applying this methodology. Please, Elisa.
As we said in the first phase, that we published an open call in order to collect market innovative ideas for planning a tender. We organized several meetings in which we explained to the market our approach and to receive guidance from them on possible metrics that could measure the value of the value-based proposals. These meetings occurred from June to October 2023, in which we have been able to collect about 10 proposals on different product categories, as well as cardiac prosthesis or intraocular lens. Now I will explain in detail two of the products that we have considered the most technically relevant, and intraocular lens and transcatheter aortic valve implantation are this. The aim is to collect market ideas in order to plan a tender after having identified the most interesting and concrete proposal. ARIA has already organized a market meeting to explain the methodology in high level in order to let the market know our goal and the opportunity for them to introduce innovation to the system. Market share with us some innovative proposals with their value and metrics. We focus on two types of products, cardiac prosthesis and intraocular lenses. There are two ways in which cardiac prosthesis could provide value: extra equipment and advantages of post-intervention patient care. We could measure them through reduction in associated additional surgical intervention and through simple management of the implant procedure. And about intraocular lens, we could evaluate the value in terms of recovery of the visus of the cataract surgery and measuring intermediate visus, and the reduction in the number of follow-ups for visus assessment and the reduction in the number of glass prescriptions. The second stage consists in the evaluation of all submitted proposals according to the concreteness about value. At this stage, it's necessary to assess the concreteness of the value, the interest associated with the proposal, and that the value of instrument is measurable and supported by data. As a result of the assessment made, prostheses were found to be insignificant in the sense of added value, while lenses being considered for the immediacy of the result and the associated available data. The evaluation criteria to test innovation can be summarized in three main topics. The value proposed must be coherent with the innovation goal of the healthcare system. The metric must be translated into numbers, the proposed value, and structured data must be available in order to measure the value according to metrics. At this point, we will proceed with the preparation of a draft of the tender for the lens, and we will measure the value in terms of result for monofocal lens for intermediate vision. And the value itself and its payment must be translated into the tender, and this is the next step we are going to approach. After that, the execution will follow. Now I'll give the floor to Marco for conclusion.
Thank you, Elisa. So for now, the next step involve concluding the ongoing experience in order to refine it with the aim of adopting the framework as a tool to support healthcare system in value-based procurement and to promote the introduction of innovation within healthcare organization. We want at the same time to make available to the industry supplier of a tool through which the industry supplier be able to promote and sell their innovation. So stay tuned. Back to you, Hamish.
Thank you so much to both of you. That was great. Just again, a reminder, if you have questions for Marco and Elisa, please do pop them in the Q&A. And without, I'm going to ask you just to stop sharing your slides, if you wouldn't mind. And we're now going to hear from colleagues from the Value-Based Community of Practice, and we're starting with Carsten Kierkegaard, who is from the southern Denmark region, I believe. And you're going to talk to us about an OBA for knee prostheses. We can see your slides.
Can you hear me out?
Yes.
Yes, okay. Thank you. My name is Carsten. I'm working as a category manager in the region of southern Denmark. And I'm going to tell you about a pilot procurement we did. We started up in 2007 and 17. And we have actually have 5 years of results right now. So, yeah, the region south of Denmark is 1/5 of the population in Denmark, and it's about 1.2 million. So in a European context, it's not a big region, but we have 5 hospitals, and the hospital I'm going to talk about is the hospital in Vejle, where we did this pilot procurement of knee implants. Yeah, the pilot is focused on total knees and partial knee replacements. So we're not talking about knee revisions. They're more complex. Yeah, when we started up, more or less, the context in our region was that we have to work more with data. We have to work with the patient experience outcome. We also had to work with streamlining this patient pathway. So that's more or less the setup. Vejle, in a Danish context, is one of the best medium-sized hospitals in Denmark. And if you look at the orthopedic department at Vejle Hospital, it's in a Danish context, it's a high volume department with more than 200 knees and hips replacements surgeries each year. When we started out, what we wanted was to improve the patient outcome for the primary knee replacements, and also if we could do better than the baseline, we wanted to reward the suppliers, and if we did worse, we would like to penalize these suppliers. So, and also when we started out, we wanted to start out within the current budget framework at Vejle Hospital, so they didn't need more money to do this pilot. More or less, the window which was open at the moment was that we had to do a new contract, and we had got feedback from the suppliers. We did the first tender in 2011, and Some of the feedback from the suppliers was that we focus too much on cost. We should, if they should offer the new implants, we should focus more on the outcome. So that's what we try to do with this new tender at Vejle Hospital. We're talking about a lot about in which areas can you do value-based procurement. We are working with category management in the region of southern Denmark, and we see that knee replacement surgery is a strategic service for the region. So that's why we work with value-based procurement in this area, where we focus on long-term strategic collaboration, focus on outcome development, risk sharing, and total cost of ownership. It's also very important to when you do a value-based procurement, that you have the ownership, that the clinical and there's clinical ownership to what you do, because you can, in my experience, implement this without support from the clinical leadership and also for the clinician in Denmark. So, and if you look at as I told, a lot of the suppliers came with feedback from the earlier tender that we should focus more on outcomes. So when we presented this idea to them, they were very keen on trying this out. So we had like 6 players who did it. We had like a pre-tender market dialogue where we discussed our objectives and also discussed the risk they saw with this type of tender. Yeah. So, and also we have, like as I said, you need to have teams where you look at this in a different way, because when you're going to do it in another way, you also have to reduce the risk from the surgeons. Some of the surgeons didn't like this more transparent approach to it, because they thought if they did something wrong, that it would be visible for everyone to see that they had done a bad job on this patient. But so you have to more or less to make sure that you involve all the right people in order to how to manage this type of risk. So, and also it's important that the suppliers involve not only the salespeople, because when you do like a value-based approach, you have to do it in another way, and they also have to change their business model in order to make value-based procurement possible. So what we achieved by this dialogue before the tender was that the suppliers got an understanding of the objectives of the region, and also we discussed possible solutions. Also, as I said, we focused on primary needs, because that's what's possible to measure. It's too difficult to measure revisions because it's too complex. There's not 2 identical patients, so you can do it in revisions. So we focused on primary knee replacements, and also we had this discussion, understanding of the risk associated with the patient outcome agreement. And if you look at what value creation levels we looked at cost drivers. We looked at if we could shorten the time in the hospital, it would lower the cost for the region. Also, if we could lower the readmission rate, we would also lower the cost for the hospital. Again, lower revision rates, it will also lower the cost. And also, if a supplier did below the baseline, they would have to pay for these implants. So that would also lower our cost when we do this type of agreement. And also, more or less, we expected that if the patient is more satisfied, they're going to through we measure on all patient experience and better functional lives. We also expect that if they're more satisfied, then they're less common to disturb the department, because when they have it, they're not going to contact the orthopedic department. And also we expected lower revision rate. So more or less what we wanted to was make sure when you did this new type of contract, we wanted to more or less to make sure that the suppliers took part of this risk from when you change from one knee implant system to another, and more or less with this contract. So, yeah, I have been to that. More or less, when we did the baseline, we used 3 last year's publicized outcome in the Danish knee replacement database. So in that way, it was transparent from the suppliers. They knew what the Vejle was performing at these outcomes. They could also see how their implants were performing in other hospitals in Denmark on the same outcomes. So more or less, they had an idea if it was possible for them to do better than the baseline Vejle. Yeah, and when we started out, more or less, we started out with all the patients who received a primary knee replacement Vejle should be included in the measurement. But what we have found out is that due to this COVID pandemic, there has been a shift of patients to the private hospitals, because the public hospitals don't have enough capacity to do all the patients. So a lot of the less complex patients have moved to private hospitals, and now it's more complex patients that have at Vejle Hospital. And you also have to make sure that you have an agreement who can adjust to that, because else it's not fair for the suppliers that right now they're receiving lower outcomes, but it's due to the change in the patient rate, not to the difference in outcome of the implants. And if you look at this, more or less, we tried to reduce the risk for both the suppliers, but also for the region. So the prices can go up with 17%, and they can go down by 17%. So that's more or less the range that the price can go up and down. And also, if you have the baseline and an implant and there's the number of revisions is above the baseline, the supplier has to pay the revision implants for the number of patients who has to revise about the baseline. Yeah. I think what's important to succeed is that you have like a well-planned clinical implementation of these knee implants, involving all relevant clinical staff. You have to make sure there's education support before or during the first and also the complex knee procedures for all relevant clinical staff. And also, in Denmark, it's not a big task when you already are collecting these metrics and reporting them to the database in Denmark. So it's not a lot extra to do that. So, and if you look at we actually have 5 years result, but I haven't looked at the latest year. But more or less, if you look at the outcome right now, you can see what we are measuring. More or less, you can see that for the 4 years results, which is available, you can see that the suppliers has been awarded by 8.7 price increase due to better outcomes. And again, if you look at the patient-reported outcomes, the prices has reduced by 1%, because if you look at this functional lift, it's below the baseline. So, Yeah, I think that's more or less what I have.
Carsten, thank you so much. That's great. We'll take the questions at the end of the webinar if we may, but that's just brilliant. Thank you. Really excellent example. We're going to pass over now to Sophie Carlier, who's from France, used to work in Paris, but now doesn't, I don't think. And you're going to present on perioperative hypothermia prevention. Thank you, Sophie. We can see your slides. But we can't hear you.
Perfect. Do you hear me?
Yes.
Thank you. So I'm Sophie Carlier. I'm the head of European and Transformation Procurement Programs at UniHA, which is the French leading public healthcare group procurement organization. And I will present you a project that took place between 2018 and 2022 in France in 3 hospitals, which is the perioperative hypothermia preventive initiative, with the learnings and our ambition. First of all, I will share with you some scientific and procurement insight, and in the second part, I will present you the results and the do's and don'ts, and I will end with our ambition. So the initial problem is that patient core temperature drops during the anesthesia. And we consider that hypothermic patients have a temperature below 36 degrees Celsius. This has an adverse, effects to the drop of temperature, such as wound site infection, myocardial ischemia, cardiac disturbance, many other adverse effects that have a cost. The statements that we had in 2017 is that despite having a warming system, we had in France 90% warming percentage of procedures with warming systems. Despite this, only 53% of the patients were still hypothermic. In the meantime, and this is something which is very important in our value-based procurement projects, we rely on the scientific, I would say, experts, and in this case, it was the learned societies. So first of all, we followed clinical guidelines of the NHS with NICE that described the temperature monitoring protocols using active warming in pre-ops, intra-ops, and post-op. The French Learned Society, which is called SPAR, made the same recommendations at the 2 years later. There was a need. It was confirmed that we had a need to provide a complete solution with an effective warming, active warming solution, combined with a protocol to monitor the temperature and ensure compliance to these clinical protocols. That was very important. Long story short, perioperative hypothermia generates adverse effects that and extend the length of the duration of stay and increase the cost. From a procurement perspective, we launched the first VBP approach applied to this solution in 2018. And we set a competitive dialogue, resulting in defining a solution meeting the need to optimize perioperative hypothermia treatment. And we signed a performance-based contract with 3M at the time, combining both a temperature management solution with a service of the hospitals to the hospitals, and we implemented this solution in 3 hospitals. Unfortunately, this started during the COVID-19 crisis, but I will share with you the results in a minute, which were promising. In this case, the objective was, the target was pretty simple. It was that 80% of the patients with perioperative normothermia patients rate above 36%. So this was the target that was set by the scientific community. The remuneration was based on the achievement of or not of this target, with a mechanism of bonus malus, and from that to that extent we moved to a transactional approach, to a value-based approach with this project, which was the first VBP project at UniASHA. In terms of outcomes, this is the example of Arras hospital, which shows that moving from 62% to 82% of normothermic patients rates enables to increase we managed to increase the number of normothermic patients by almost 4,000 per year, to reduce the incremental length of stay related to the surgical complications by 52%, to avoid 28% of surgical site infections per year, and avoid 17% of morbid cardiac complications per year, just by increasing by 20 points the number of normothermic patients. In the other hospitals, which is the hospital of Saint-Etienne, which is a university hospital, here as well we have the same trend. We moved from 57 to 75% of normothermic patients rates with this solution, and in the same with the same trends, we increased the number of normothermic patients by 4,000 approx. We decreased the duration of the length of stay. We decreased as well the surgical site infection rates by 23%, and same trend in terms of morbid cardiac complications decrease. In terms of learnings, what is very important from our perspective is really to work very closely with the scientific community, same as you saw in the previous examples, with a strong clinical leadership, strong management support also of the hospital, team collaboration between the supplier and the hospital's team. This robust scientific track record also enables us to define the target. Accessible data is very important. This was mentioned also in the Italian example. Clear definition of the scope of the expected value and the outcomes, the results, and the KPIs, and change management, of course, is very important. What we will do, because we will relaunch this project very soon, is really to avoid complexity in the evaluation process, and also set a pretty simple remuneration model of the vendor. We need really to keep the momentum on this project in the long term, and this is why we will leverage these experiments to scale up a more compelling and easy to use VBP offer in the upcoming, I would say, weeks. We will launch this. We will launch the project, and in very soon as well, we plan to launch publish a tender with a focus on simplification, and we expect to reinforce a value-based and innovation procurement program involving clinicians, societies, patient associations as well. This was not done in this project, but we will do this in the next one. Hospital senior management, procurement, of course, and we really want to pioneer VBP and innovation procurement in France. As this, we can easily present this one, but there are a number of other projects that we are currently preparing. So in this, we had a lot of publications on this project, and that was led by the team of UNEHA, which was based in Lyon. Valérie Mermet, especially, and Anthony Moreau, and we have also 2 other team members from the biomed procurement team, and also the pharmacists are in charge of medical devices, which was involved in this project. So this is what I can say, Hamish, on my on our project.
Sophie, thank you so much. And again, a really elegant example of value-based procurement in practice. So thank you. So amazingly, we're at or just slightly ahead of time, which is great. So we have some time now for discussion and questions with all of our speakers, and we've got 1 or 2 other panelists as well. Carlos, shall we just start? Please do, colleagues, if you have questions, put them in the Q&A and we'll pick them up. But I'm sure we'll have a good discussion. So, Carlos, do you want to start?
Yeah. Yes, thank you, Amish. Yeah, we have already received some questions. Just a reminder, if you have any more, please post them in the Q&A section. We'll go through them. If it's okay, I will start reading, and let's see which one of our panelists is the most suitable to provide an answer. The first one is from Carl Lander. The question is, why wouldn't you involve patients every time? After all, they are the people who know what outcomes are of value to them.
Thank you, and Borada, Carl. Perhaps I'll start with that, and then maybe we'll draw in Sophie and other colleagues too. It's a good point, and I think it's a pragmatic question, isn't it? Is that I think we're on a journey towards making sure we are capturing patient-reported outcomes at scale, but in order to include patient views or patient outcomes into the procurement, you do need to have the data. So that's one of the challenges. But there is no reason why patients can't be involved. I'm not a procurer, but in theory, there is no reason why you couldn't include them in the determining of what matters, the outcomes, even if you can't then always measure those outcomes initially. But Sophie, I noticed that in your presentation, you said that in your next round of this, you were going to include patients. So perhaps you can share your view.
Yeah, I will share it, and afterwards I saw that Carsten raised his hand. So thank you, Carsten. So patients, it's are critical and instrumental as well in the change management. If we want to measure the outcomes with PROMs, patient-reported outcomes measures, or with PREMs as well, patient experience, it's very important to involve them, and we see more and more the patients, I would say, power in the healthcare policies, and this is why in France, in our projects, we think that it is crucial to involve them.
And can I just put you on the spot a little bit? Will you be involving them just in the kind of design of the procurement, or will you be actively looking to include patient-reported outcomes in the measures?
They will be involved in the governance. It was not the case in this project, but in the future one and in other projects that we are currently preparing, they are involved in the governance, and they are part of the discussions to design the way of evaluating the procurement performance with outcomes that can be clinical or patient-reported.
Fantastic. And Carsten, your view. I mean, I noticed, you talked about another important concept, which is this idea of a multidisciplinary team approach to procurement. Does that include patients?
I think if it's possible to connect the patient outcome to the patient pathway, But if you have a patient pathway where you use multiple products, it can be difficult to connect the patient outcome to a specific product. So if you don't have this possibility, I think it will be hard to do patient value-based outcome, because you need the connection in somehow. And what I see is, in order to do this, maybe we have to move from buying products to buying a whole bunch of products to a pathway, in order to, if you want to do this in the future, because if it's the combination of different products who actually ends up is important to the end result, you have to buy more procedures instead of individual products.
Okay, so I think, Carla, a view there that it is good to involve patients, and people are trying to. I don't know if any of our other procurement panelists are. So, for example, Elisa, are you including patients in your intraocular lens procurement?
We have to consider if the patient is connected to the value, because if the value is connected with the healthcare system, we have to manage with the healthcare organization. Otherwise, we have to talk with patient in order to understand something about the situation or condition of patient itself.
I mean, I think it's an interesting, the cataract intraoperative lens product has been both in France and in Wales have had very similar results, which is that if you look at the clinical outcome, then by and large, it's very successful. But if you look at the patient-reported outcome, which is visual functioning, about a quarter of patients see no improvement or get worse following the surgery. So it's a really nice example of where the clinical outcome and the patient-reported outcome are very different. And I would suggest, and I suspect Carl would agree, that that it's the patient-reported outcome that is the important thing. It's whether they can do the things with their eyes that they want to be able to do after the surgery. So it's actually a well-studied example of that. So Carlos, let's perhaps move on to the second question, and we can come back to this question in a minute.
Okay, the second question, there's no name to it, and I'm not really sure if I understand, but maybe you do, is would you consider some technologies, groups, or categories not fitting to value-based procurement at all?
Yeah, so I think that is a really good question. Is value-based procurement something that can be applied to everything, or are there some things that it's not suitable for? And I touched on this very briefly when I was saying you have to decide whether the product you can operate an outcome-based agreement for a particular service or product. Marco, you have your hand up.
Yeah, it depends on the value we want to address. With a value-based procurement tender. So the connection between the technology we want to buy and the value we want to discover. So in theory, there is not any limitation about the product category which can be involved in a procurement, in a value-based procurement tender. It depends on the value we want to discover. We want to. The healthcare system is able to pay in order to discover the value. This is the key.
Okay, so Marco would have everything potentially if you can measure it. Hans, what's the industry view?
Yeah, I would agree to Marco. The starting point is that every medical device, every technology you buy, should have an impact. It should deliver value, because when it doesn't deliver value, you should not buy it or use it, right? So all what you buy is aimed to produce an impact on patient outcome, on efficiency of care. And then you can apply this methodology to any type of medical device. And this is what we see in the community of practice. So when we have the long list of value-based procurement case examples, it really ranges from very high sophisticated equipment like robotic surgery to implants, but also to wound dressing, sutures, and even incontinence care products, right? So it basically can be applied to anything as long as you buy a medical device to produce an impact and it should deliver value. And again, if it doesn't produce any value, then you should not buy it in the first place.
So can I just challenge that and say, what if it's something where the value isn't realized for a long period of time? So if I took a medicine example, statins, which most adults are now being prescribed, the outcome is something not happening in 20 years' time. So not having a heart attack in 20 years' time. Do you think it would be easy to design a procurement that reflected that outcome?
Yeah, I think you could, but what also basic element in this value-based procurement approach is that we say there might be a difference in the offering by medtech suppliers, right? So we expect a value to be delivered, and in the different product offerings or the solutions being offered, there is a difference, and that's what you take into consideration when running a tender.
Thanks very much, Hans. Carsten, what do you think?
I think in our region, more or less, we're working with categories management, and we have like this strategic square, more or less. When we talk about value-based procurement, we're looking at that because that's more or less our standing point. But I agree with Hans, it can be in every product group, you can do that. But we focus on the strategic services our region has to provide in order to focus what are we going to do, because in our region we have about I think it's about 80 or 100,000 different products. So we can't do value-based procurement in all of these products. So we have to focus on where we see the best potential.
Yeah. So there's a sort of pragmatic answer, which is it's just too difficult to do it across everything. So prioritize where you think you'll get greatest value. Okay. Thanks very much. Next question, Carlos.
Okay. Next question. Given the complexity of outcome-based approach through tenders, do we see more traction for value-based procurement approaches with large regional health systems or procurement platforms than individual hospital or hospital networks?
Yeah, so that's again a really interesting question for procurers. Is that is the complexity and scale of this? Is it easier to do it at scale, or can you do it in a small scale local way? And maybe Sophie, from your national perspective as well, it'd be interesting to hear that.
Yeah, of course, we need to be very close to the hospitals, and that's why our teams are embedded in the hospitals. But there is something which is very, very important to make it work also is the payment reimbursement, piece. If we do not consider this, we might face some issues. And that's why, same as in Denmark, we work with multidisciplinary teams, and we start to involve payers, in our approach, because we might have a medical device which has a real impact, but which is not very well reimbursed. And this is a component that we need to consider to scale up.
Thank you. Ola, it would be, I know that you represent a national procurement organization. Do you have a view from Norway, if you're there with us? Okay, we'll perhaps come back to you in a minute. Carsten.
Yes, I think in some ways, it's easier to do it at a department or hospital level, because there has to be a level of trust between the clinical staff and the supplier in order to go into this type of agreement. And more or less, also in our region, we have like, I think it's about 8 to 10 hospitals. And some of these hospitals is it difficult to attract and maintain qualified surgeons, and they wouldn't be very attractive for a supplier to do this type of agreement, because they would have to train surgeons all the time in order to achieve the result they more or less would like to obtain. So you larger, the more risk the supplier has to take. If you do it at a hospital level or regional level, it's easier to comprehend the level of risk that the supplier have to manage with, because if you do it larger, the more risky I see it. So.
And Marco, in terms of the kind of resources to operate an outcome-based agreement, is it something that's easier done at scale at a regional level in your case, or do you think it's best done locally?
Yeah, in order to measure the value of, for example, for IOL, it depends on many factors. For example, for the surgery, for the clinical condition of patients. So for us, it's better to give the additional payment based on a measure on a larger set of cases. So it's better for us in order to, I don't know, say neutralize. I'm sorry, neutralize as a word. So neutralize this factor, factor that does not depend on the procedure, to evaluate the value on a large scale. So for us, it's better to apply in a regional scale.
Yeah. So there is something about having sufficient data to smooth out the variations. From our research, we found that if you just have one measure of outcome, you can have a lot of noise in the system and quite big variance year from year. Whereas if you have a number of outcomes that you consider in some way as a basket or as a group of outcomes, you can neutralize some of the variance the big swings in outcomes that you might get. Carsten, your hand is still up. Did you want to come back on that?
Yeah, that's more or less. When we talk about this, we talk about you need at least 200 patients a year, because if it's lower than that, one patient more or less can change the result. So you need a certain number of patients in order to do this time of a contract. So if it's below 200, it's difficult. So,
okay.
Yeah.
So you need volume for value. That's good to know.
Yeah.
Okay. Should we move on to the next question, Carlos, and see if we can get through a couple more?
Next question is directly addressed to Sophie, and it says, as LOS and SSI are multifactorial, how could you ensure that the results were due solely to the intervention?
Can you say it again? Sorry.
Yeah, it's so because length of stay and surgical site infection, there are many causes of those, or many drivers for that. How did you know that the management of temperature was responsible for the change?
So unfortunately, I cannot answer to this because I didn't manage the project, but it was for sure linked to we cannot define some KPIs without linking them or liaising them with the outcome. And this, I can answer this question to the person later on, if and maybe to you, so that you share it with
yes,
with the audience, if you don't mind. But it was for
it's a general question, isn't it? Which is how do you allow for, clinical care is complex and multifactorial. Yeah. And it comes down, I think, to the importance of having the baseline data, isn't it? And if you just have to make some assumptions that the other factors are the same in the baseline and in the intervention, and it's the intervention therefore that is contributing to the difference. But if you're the buyer, you're having to take that risk anyway. You're buying the warming system because you believe it will make a difference on top of the other things that are happening.
Yeah, but what was done actually is that we did measure the hypothermia rate and use the health economic model, which was validated by NICE to estimate the impact on site infection, on cardiac event also, and length of stay. So all this was scientifically driven, and we couldn't invent or set our rules, our procurement rules, without this scientific norm, if I may.
Yeah, okay, thank you. And just we've quickly from Marco and then Carsten. Marco or Elisa, what's your view on that? You're on mute. Oh, you've gone. Oh, there you are. Yeah.
Well, it was previous speak.
Carsten.
Yes, in our model, what we're doing is that if you look at infections, more or less, we try to reduce this risk associated with infections. And if you look at the Danish knee replacement database, you can see that the cause about 25% of the revision is infections. So more or less, when we look at the data, we say if more than 25% of the bad results is due to infections, we don't take them into account, because that can be a local problem at the hospital. They have a problem with infection or something, more or less. That's a way to reduce the risk for the supplier also.
Yeah. So that's back to your baseline, having a good baseline data to work it out. Excellent. We've probably got 2 minutes left for questions. So let's just take one more. Should we take the question from James, Carlos?
Okay, the question for James is, how do you segment the therapy areas to be prioritized for this value-based procurement approach?
Okay, so very quick question from the three procurers. From Sophie, how are you prioritizing what to look at first?
Actually, we need to, all starts with a need or an unmet need, and we make an assumption that the solution should have a great impact. So this makes sense from my perspective, but that's the way we approach it. Another condition is also to have the data or automated data as much as possible, and again a scientific and medical team which is motivated to run these projects. We need also to stick to the health policies of our countries, and this helps, especially when we have to interface with in the governance with some decision makers, especially for payment or reimbursement, for instance.
Thank you very much. And Carsten, how are you prioritizing? What are you going to do next?
Well, we have just introduced robotic surgery at Vejle Hospital. So we do that on the knees also, and we have included hips in the model also. So that's what we're doing. We have done just last year. When I'm going to do the tenders on the hips and knees for the rest of the hospitals, we're going to use this model as an option. So if there is a trust between the winning supplier and the department, they can go into this type of agreement afterwards. But we're not more or less doing as part of the tender. We're looking at who's going to win, and afterwards to see if there's a match between the supplier and the hospital.
Okay, and then just finally, colleagues from ARIA, you've told us the two of the things you're going to look at. How are you prioritizing? You're based on the response from the market?
Yeah, we organize an open call, and we listen to the market about their solution, their proposal, but we have to evaluate concreteness too, and we have to evaluate it if we can have the data, as Sophie said.
So okay, so some practical considerations and market perceptions as well. Carlos, your hand is up.
Well, yes, I just wanted to share how we're doing this in Andalusia, this prioritization. It's not about technology prioritization, not system prioritizations. What do I mean by that is that we have to focus on what we're doing is, as Sophie says, and emphasizing that we focus on defining what are our needs, and we do that with the end user, mostly clinician, but we also try to incorporate patients on board. It's not that easy. And then there is an evaluation focus on the, how do I say this in English? Pertinency. And that's what does it mean by pertinency? But there is a clear link with what has the most value at the moment for our systems. And we also incorporate in the decision all the chain in command, chief of services, medical chief of services, hospital management, and so on. And we build a prioritization of needs. And from that, we also, for sure, have to incorporate a value-based approach when we try to adopt those innovations. Just how we do it.
Good. We're going to have to stop there, I think. Otherwise, we're going to run out of time. We've got some great questions not answered. I apologize for that, but we will answer them. So thank you very much to Marcus and Xavier and Benoit and Nikki and Sonia for your questions. We will come back to you on those afterwards. Really just to thank everybody, to thank all our panelists for some really great presentations, practical examples from all of you, and for your contribution to the discussion, and of course colleagues who've from TIC Biomed and Carlos, who've helped to organize this, and also the community of practice. Just to pick up one or two key points, I think. The first is it is clear, isn't it, that value-based procurement is important. It's an important thing that we should be doing, because procurement is a really important part of the whole value-based ecosystem, and as we know, it's where a lot of the resource, a lot of the financial resources is going. So really important, and it can help to shape and drive systems to be more value-based as well. It needs to be set in the context of solving problems, and we've heard that from several speakers, and that question about prioritization. Well, what are the problems that health systems are trying to fix, and how can value-based procurement work? It is quite technically demanding, and it can take a while, I think, to develop these agreements. But if everybody is committed to trying to do so, then it can be successful, as we've heard from some great examples today. And it's really encouraging, I think, for all of us who are interested in value-based procurement to see it being done, and being done well. And it is really important to share the learning, because there is a lot to learn about it, and that's why Procure for Health is so important, and it's why events like this are so important, and it's why the value-based procurement twinning event that we'll be holding in June will be helpful. We heard from Hans that this is a kind of new paradigm, a new way of working. And it's important to really, all products should be impacting on outcomes, and if they're not, we shouldn't be using them. We heard from Carsten and others, Sophie particularly, of the importance of a multidisciplinary team. Procurement professionals have real expertise in procurement, and clinicians have real expertise in clinical care, and together they are a really powerful force, particularly if we can get the patient voice there as well. But very often, and certainly in the UK, there is a tendency to keep clinicians and procurers as far apart as possible, and that just seems crazy. So great to hear that you're doing all that, and it's important to see that you are trying to solve problems as well. So we've had some really excellent learning today. Just in the final couple of minutes, so next steps, what are we going to do in Procure for Health? Well, there is going to be presentations at the MedTech Forum in Vienna on May the 23rd, if any of you are going to that. It looks like a really good meeting. There is a Procurement of Innovation conference that I think colleagues in Medtronic are helping to run in Athens on the 30th of May. And again, there will be an opportunity to talk about how you innovatively procure innovation. The Procure for Health project itself will have an action plan and capacity building, and it has a website where there's some fantastic resources, and suppliers and procurers are invited to look at that. And I'll just quickly come to Carlos in a second to say how you can do that. And then just finally, for partners in Procure for Health, there is a twinning event on value-based procurement, again getting in depth into some real-world examples on June the 10th in Wales, and we'll be sending out information about that very shortly. So Carlos, just perhaps finish, thank you, and perhaps tell people how they can find stuff on the website.
Well, thank you very much, James. And you're completely right. This has been a very, very interesting conversation. Just to briefly let you know that everything, we have obviously a web page in which all the information is, you just want to see what's going on and gather all the info, presentations, recordings, and so on. It's available there. But if you want to engage deeper into Procure for Health activity, you can also register in our platform. It is open for all types of organizations, procurers, supporting organizations, and suppliers. If you are a supplier, you might only have access to certain types of activities, but anyhow, anything related to engaging with the innovation ecosystem, it will be available there. Also, just to point out, it's very interesting what's coming up regarding the open market consultations we're launching, since these are already prioritized common needs from procurers across Europe. So, I mean, all the information is there. So stay tuned. Fantastic.
A great way to finish. So thank you to everybody. Thank you, Carlos. Thank you, Maria, for keeping us on track. And we'll end there. So, and thank you to everybody who's participated today. Thank you.
Thank you, everybody. Bye.
Bye, everybody.
Thank you. Bye.